Good evening, everyone. Today we are going to talk about toxidromes. It's very rarely talked about in some of the countries, so I thought I would take this one. It is becoming more and more common in recognizing and treating appropriately. And also, what we used to do earlier has been changed over the past many years. So we are going to touch upon it. Please stay with us till the end. And we are going to talk about initial evaluation and the different toxidromes and how to approach and how to treat and how to dispose the patients. Before I start the topic, I wanted to introduce a word called xenobiotics. It's not that commonly used. What xenobiotics are, they're chemical substances are foreign to a biological system, including drugs, pesticides, environmental pollutants, and other man made chemicals. They can be natural compounds at high concentrations or artificial substances that did not exist naturally before human synthesis. So, we are going to use this word commonly instead of just drugs because toxicology is not just coming from drugs alone. It can be pesticide and other environmental pollutants, etc. Initial evaluations, we are going to talk about 8 different toxic syndromes or toxidromes: anticholinergics, cholinergics, ethanol or sedative hypnotics, opioids, serotonin toxicity, sympathomimetics, withdrawal from ethanol or sedative hypnotics, and withdrawal from opioids. Some of them are familiar to you, some of them talked about during school years and also during training. Here we wanted to bring all comprehensively all 8 syndromes and we will discuss it in detail. During evaluation, the first one you evaluate is blood pressure. The xenobiotics can cause hypotension, hypertension, sometimes in combination. It evolves over time. The hypotension often happens because of decreased peripheral vascular resistance, decreased myocardial contractility, dysrhythmias, and depletion of intravascular volume. Hypertension happens as a result of sympathetic overactivity, increased myocardial contractility, or increased peripheral vascular resistance or combination thereof. Sometimes the blood pressure can vary. Initially hypertensive, then they become hypotensive. For example, in monoamine oxidase inhibitors, initially they start with normal blood pressure, then hypertension happens when the medication really hits, and then hypotension happens. So you have to keep in mind the dynamic things that could happen with various xenobiotics. So, what are the xenobiotics causing hypertension? As we all know, alpha 1 adrenergic antagonists, alpha 2 adrenergic agonists, especially those acting in the centrally, beta blockers, beta 2 adrenergic agonists, AC inhibitors, angiotensin receptor blockers, antidysrhythmics, calcium channel blockers, and cyanide. And also cyclic antidepressants, ethanol and other alcohols, iron, methyl xanthines, like that happens with aminophylline, nitrates and nitrites, nitroprusside, opioids, most commonly we come across with fentanyl overdose, phenothiazines, phosphodiesterase 5 inhibitors, and sedative and hypnotics. Xenobiotics causing hypertension, alpha 1 adrenergic antagonists, alpha 2 adrenergic agonists, central early on, initially it causes hypertension, then it causes hypertension. Alpha 2 adrenergic antagonists, ergot alkaloids, ethanol and sedative hypnotic withdrawal. Sedative Ethanol and sedative hypnotics causes hypertension. During withdrawal period, hypertension can happen. Chronic lead poisoning, MOO inhibitors, overdose early and drug-food interaction causes hypertension, nicotine, pencyclidine, and sympathomimetics. After the blood pressure, look at the pulse rate. So where to check the pulse rate? Carotid artery is usually easily palpable, but brachial artery is preferred in infants. Radial artery in adults older than 60 years. The way defined in adults, bradycardia is when the heart rate is less than 50, tachycardia when the heart rate is more than 90. In children, based on the age, the cutoff for bradycardia and tachycardia is or different. Please reference to those manuals that depicts each and every year the heart rate differentiation to keep them in bradycardic or tachycardic range. The xenobiotics causing bradycardia, alpha-2-adrenergic agonists, beta blockers, baclofen, calcium channel blockers, carbamates, cardioactive steroids, and also cigotoxin, ergot alkaloids, gamma hydroxybutyric acid, opioids, organophosphorus compounds, and synthetic cannabinoids. The drugs causing tachycardia or xenobiotics causing tachycardia, alpha-1 adrenergic antagonists, anticholinergics, antipsychotics, beta-adrenergic agonists, cyclic antidepressants, disulfiram ethanol interaction, ethanol and sedative-hypnotic withdrawal, iron methylxanthines, pencyclidine, sympathomimetics, thyroid hormone, thiamine deficiency, and yohimbine. These are all can cause tachycardia. Respiratory rate evaluation is very important, including what is the respiratory rate in that patient. In addition to the rate, depth and retractions also needs to be recorded and observed. And the tachypnea can be just increase in the rate along with increased depthness with retractions or combination of both. Especially when the patient took CNS stimulants such as salicylates, it stimulates the brainstem that causes hyperventilation. Sometimes these xenobiotics can cause aspiration, resulting in pulmonary injury that can cause hypoxemia and tachypnea. Metabolic acidosis that results from either hypertension or disease per se or xenobiotics per se, as it happens in salicylate, can present as tachypnea. Bradypnea happens because of brainstem depressing acts that happens in opioid overdose. Cyanide carbon monoxide can progression from tachypnea to bradypnea. So the observing the rate of breathing, depth of breathing, and the dynamism that could happen from fast to slow needs to be observed. So the xenobiotics causing tachypnea, cyanide, dinitrophenol, epinephrine, ethylene glycol, hydrogen sulfide, methanol, methemoglobin producers, methylxanthines, nicotine, pulmonary irritants, salicylates, and sympathomimetics. Xenobiotics causing bradypnea, alpha-2-adrenergic agonists, botulinum toxin, carbamates, lapidavinum, ethanol, and other alcohols, gamma hydroxybutyric acid, magnesium, neuromuscular blockers, opioids, organic phosphorus compounds, sedative hypnotics, tetranospasin, and tetrodotoxin. Then, finally, among vitals, temperature. When you check the temperature, just make sure the temperature recorded is reliable one. For example, if the patient is tachypneic, checking oral temperatures may not be accurate. And also, those who exposed outdoors, axillary or temporal artery temperature may be misleading. Sometimes tympanic temperature may be misleading in a patient with cerumen impaction. So all this needs to be considered when you rely on the numbers you get from the nurse. The most reliable the temperature measurement from core temperature or rectal temperature under normal physiologic circumstances. So how do you define hypothermia and hypothermia? Hypothermia is defined when the temperature is less than 95 Fahrenheit or 35 Celsius. Hyperthermia is defined when the temperature is more than 38 centigrade or 100.4 Fahrenheit. Life-threatening hyperthermia is defined when the temperature is 106 Fahrenheit or 41 centigrade. It leads to extensive rhabdomyolysis, myoclonus, kidney failure, and direct liver and brain injury. So, avoiding hypothermia, that range is very crucial, and also look for rhabdo or acute kidney injury or liver and brain injury at that point. The hypothermia is because of internal generation of heat beyond the capacity of the body to dissipate heat that occurs in patients who are really agitated badly, mitochondrial uncoupling that happen in salicylate toxicity, environmental exposure that happens in heat stroke, and excessive swaddling that happens with infants. It all needs to be identified and treated accordingly. For example, infants, the high temperature could be because of excessive clothing that needs to be removed, agitation needs to be controlled, so on and so forth. So xenobiotics causing hyperthermia, anticholinergic, chlorophenoxy herbicides, nitrophenol and congeners, malignant hyperthermia, monoamine oxidase inhibitors, neuroleptic malignant syndrome, and also pencyclidine, salicylates, sedative-hypnotic or ethanol withdrawal, serotonin toxicity, sympathomimetics, and thyroid hormone. The xenobiotics causing hypothermia, alpha-2 adrenogen glands, anesthetics, cannabinoids, carbon monoxide, ethanol, gamma hydroxybutyric acid, hypoglycemics, opioids, sedative hypnotics, particularly barbiturates and thiamine deficiency. So I'm going to walk through certain toxidromes well known to some of you, and for some of them it's new, but we'll kind of walk one by one. In anticholinergic syndrome, the pulse rate and the temperature is higher, and the BP and the respiratory rate may be normal. But these patients, anticholinergic can cause delirium along with dry mucous membrane, flushed appearance, urinary retention. Pupils are dilated. So if you see a patient with high heart rate, high temperature, dilated pupil, dry mucous membranes, and urinary retention, think in terms of anticholinergics. Cholinergics are opposite. They predominantly have normal to depressed mental status, increased peristalsis and diaphoretic. They will have salivation, lacrimation, urination, diarrhea, bronchoria, fasciculations, and paralysis. So you need to observe those kind of signs and symptoms, and of course, treat accordingly and yearly. Ethanol sedative hypnotics, most they are kind of uptended. All those parameters will be lower, blood pressure will be lower, pulse rate, respiratory rate, temperature can be lower, and the peristalsis will be decreased, so they will be hyporeflexic and ataxic, and mental status will be depressed or agitated. Opioids, similar spectrum, blood pressure, pulse rate, respiratory temperatures, all will be lower, mentally depressed, and the pupils will be constricted, low peristaltic movement, and hyporeflexic. Serotonin toxicity, blood pressure and heart rate is up, peristalsis would be pronounced, and they will have clonus, tremor, and seizures, then increased perspiration. Sympathomimetics, opposite to opioid, blood pressure, pulse, respiratory rate, temperature, all will be elevated. They will be agitated. Pupils will be dilated, diaphoretic, tremor, seizures, and diaphoretic. Withdrawal from ethanol and sedative hypnotics, they act similar to sympathomimetic. Blood pressure, pulse rate, respiratory rate, and temperature all will be elevated. They are agitated, disoriented. They may be hallucinating. Pupils will be dilated. Their increased peristalsis, diaphoretic. They may have tremors, seizures, and diaphoretic. So these are all the clinical syndromes one has to recognize early. And in order to recognize, you need to go through these signs and symptoms a couple of times till you memorize them. How to initially manage the patients with suspected exposure. When the patient comes in, you do not know which patient and what he took. Some of the clinical symptoms can give a clue. Sometimes they can give the xenobiotics they have taken at what time they took. The most important is just make sure there is no airway compromise, there is no breathing difficulty, and evaluate circulatory system for hemodynamic instability and dysrhythmias. And of course, look at the mental status. These all four things needs to be done immediately as the patient walks in or brought in. Assess the airway. Evaluate clinically, make sure airway is open and the air movement is good. If you suspect cervical spine injury that need to be stabilized while you are positioning the airway and using airway adjuncts. So cervical spine stabilization comes first, then put airway adjuncts that could be either nasopharyngeal airway or oropharyngeal airway or straightforward endotracheal intubation with a definite airway. Once the airway is established, and make sure the patient has adequate breathing by checking pulse oximetry and if you have end-tidal CO2 or rapid blood gas. If the patient is hypoxemic, give supplemental oxygen. Even before hooking up with pulse ox, giving supplemental oxygen is a good way to proceed with, and bag and mask ventilation with assisted respiration if the patient is not breathing adequately. And the endotracheal intubation and definite airway needs to be done if the patient is not responding to initial measures, and finally mechanical ventilation. Then assist for circulation and perfusion. And look at the cardiac monitor. Get 12-lead EKG if you suspect any cardiac arrhythmias. Establish IV access and obtain blood for testing. And do a CPR as indicated, and extracorporeal life support needs to be informed if you think the patient is in serious state. And fluid resuscitation as indicated, and antidysrhythmic therapy like atropine bicarbonate needs to be considered. And if the blood pressure is low, vasopressors and inotropes. So airway, breathing, and circulation. Then assess central nervous system. Most of the time, all can be done simultaneously, not sequentially. Clinically evaluate, look at what is the GCS is. If the mentation is abnormal or obtended, check the blood glucose and check the temperature. Support oxygenation, ventilation, perfusion, and check the glucose. If it is low, give dextrose. If you think the patient has an opioid overdose, go ahead and give naloxone. That can be therapeutic as well as diagnostic. Thiamine in a patient, in adults with alcohol intoxication. The special considerations, especially when the patient presents with seizures, treat with benzos, pyridoxine in isoniazid toxicity, barbiturates, and propofol. In xenobiotics related seizures, phenytoin need not be given. In any other anti-seizure medication, usually give benzodiazepines followed by second-line anti-seizure medications like Keppra, phenytoin, and valproate. But in toxicology, phenytoin needs to be withheld. Sometimes it can potentiate seizures, and most of the time it is not that effective. So Benzodiazepines and barbiturates and propofol is go-to when you are treating seizures in toxicologic emergencies. And thermal dysregulations. Check the temperature. If the patient is hyperthermic, sedate, cool, and intubate in paralysis, especially in neuromalignant syndrome, and use antidotes and treat agitations with sedation. As soon as you do A, B, C, D, and controlling the seizures, and identifying hypoglycemia and treating appropriately, and categorize the patient clinical symptoms into one of the toxidrome. That can be done by history and physical examination, bedside testing, and discuss with Poison Control Center. In the United States, it's much easier. Just call Poison Control Center. They will tell you A, B, C, D, you got to do this. And also they'll follow up with you and make sure the patient is responding as they're supposed to. The diagnostic evaluation includes history and physical and specific laboratory analysis. That includes blood gas, lactate, serum electrolytes, BN creatinine, glucose, CBC, and APAP, urine and serum ketones, and beta CG, especially in um, females in the reproductive age group. If suggested by history and physical, do other tests like hepatic and coagulation profile, cardiac and skeletal muscle profile like troponin and CPK, specific drug concentration, radiographic studies, and studies to exclude non-toxicologic causes. So how to go beyond after doing airway breathing circulation and mentation. Then specifically in toxicology, whether the patient needs antidotes. There are lots of antidotes are available that needs to be most of the time. For example, acetylcysteine in acetaminophen or paracetamol injury causing hepatotoxicity, and N-acetylcysteine needs to be started. It's available both IV as well as PO, and IV is much more shorter version, and the PO version is non-tasty and they tend to vomit, and also it takes a longer time. Activated charcoal. Activated charcoal was routinely used once upon a time. Now sorry, less and less used. The role of activated charcoal is adsorbent to xenobiotics in the GI tract. The reason it is not used that commonly because by the time the patient comes, it's more than 4 hours, and some of the time it doesn't work, and it makes black discoloration of mouth and the pore, and if there is a spill, whole body, and also have a coal tar like stools. But nevertheless, if the patient comes in appropriate time, activated charcoal still can be used. Atropine, it's used in Brady dysarrhythmias, cholinesterase inhibitors like organic phosphorus compounds, and physostigmine, and muscarinic mushrooms ingestions. And benzodiazepine should be used in patients who present with seizures, agitation, stimulants, ethanol and sedative hypnotic withdrawal, cocaine toxicity, chloroquine, organic phosphorus compounds toxicities. Calcium chloride is used in fluoride, hydrofluoric acid, ethylene glycol, calcium channel blockers, hypermagnesemia, beta-adrenergic antagonists, and hyperkalemia. One word about calcium chloride. Make sure the IV line you place is good one. And preferably it is in bigger vein or central line, because extravasation of calcium chloride can cause necrotic skin injury. L-carnitine should be used in valproic acid and hyperammonemias, hyperheptadine for serotonin toxicity, dantrolene for malignant hyperthermia, deferoxamine for iron and aluminum toxicity, dextrose in water for hypoglycemia, When you use dextrose in water in adults, use 50% concentration, in pediatrics 20%, in 10% in neonates. The reason being the higher concentrations are caustic to blood vessels in pediatrics and neonates. Digoxin specific antibody fragments for cardiac steroids, dimercaprol for arsenic, mercury, gold, and lead, diphenhydramine, dystonic reaction and allergic reaction, DTPA for radioactive isotopes, americium, curium, and plutonium, irritate calcium disodium, lead, and other selected metals, ethanol used in ethylene glycol, methanol, and diethylene glycol toxicities. Flumazenol is specific for benzodiazepines. Folinic acid needs to be given for methotrexate and methanol toxicities. Famiprazole for ethylene glycol, methanol, and diethylene glycol. Famiprazole is often used than ethanol in the United States. Glucagon, beta-adrenergic antagonists, and CCPs, calcium channel blockers, glucopridase, methotrexate, hydroxycobalamin for cyanide toxicity. Insulin should be used in beta-adrenergic antagonists and calcium channel blockers and hyperglycemia. Lipid emulsion for local anesthetic toxicity. Max sulfate for cardiac active steroids, hydrofluoric acid, hypomagnesemia, ethanol withdrawal, and torsity pointase. Methylene blue used as an antidote for methemoglobinemia, ifosfamide, vasoplegic syndrome, and shock. And naloxone, of course, used in opioids and clonidine overdose. Norepinephrine for hypotension, octreotide for insulin secretory induced hypoglycemia, oxygen for carbon monoxide, cyanide, and hydrogen sulfide, dipencylamine for copper, phenobarbital used for controlling seizures, agitation, stimulants, ethanol, and sedative-hypnotic withdrawal. In fact, mostly for withdrawal symptoms, the phenobarb, especially in neonates, most commonly used. Phentolamine for vasoconstriction, cocaine, monoamine oxidase inhibitors, epinephrine, and irregular alkaloids. In those patients, toxicity, pentolamine is used, physostigmine for anticholinergics. Vitamin K1 for warfarin and rodenticide toxicity, potassium iodide for radioactive iodine, polyethylene glycol GA decontamination. This is for whole bowel irrigation. The polyethylene glycol is used, especially when you suspect there is increased amount of toxic materials accumulated in the GI tract. This is a good way to do it. It's not routinely used, but it can be used in appropriate circumstances. Pralidoxime for cholinesterase inhibitors for organophosphorus compounds and carbamate toxicity. Prothrombin complex concentrate in vitamin K antagonists induced anticoagulation and oral anticoagulants toxicity in those patients. Prothrombin complex concentrate can be used. Protamine for heparin toxicity, pyridoxine for ethylene glycol, isoniazid, and gyrometrin muscarine toxicity. Sodium bicarbonate is used in cyclic antidepressants, salicylates, and metabolic acidosis. Sodium nitrite, sodium thiosulfate, and hydroxycobalamin for cyanide, succimer for arsenic, lead, and mercury, thiamine for thiamine deficiency, Wernicke-Korsakoff syndrome, and ethylene glycol. So these are all the specific antidotes for those particular toxicities. Okay, how do we assess what is the risk benefit before you do it? For example, if the patient comes with the dermal or ophthalmologic injury with xenobiotics, number one, if it is mild, just wash it with regular, normal temperature water. If it is severe, transfer them immediately to either burn hospital or call the ophthalmologist right away before you intervene. That's number one. Number two, gastric emptying. Previously, we used to do in all those patients orogastric lavage, again, based on how quickly the patient comes to you. If it is within 4 hours, one can try either gastric emptying, which is rarely been done. Most of those patients get activated charcoal, gram per kilo. The limit our absorption by us activated charcoal or whole bowel irrigation can be used again based on the type of the medication, how quickly they can get to the hospital, and the effectiveness of activated charcoal. And one has to remember if the mentation is good or if the patient is vomiting, so on and so forth, because aspiration of activated charcoal can cause severe pulmonary injury, including ARDS and increased mortality. So keep that in mind when you are choosing activated charcoal. Enhanced elimination. Enhanced elimination means there are multiple ways you can do multi-drug, activated charcoal, alkaline diuresis, hemodialysis, and hemoperfusions. We are going to talk about all of them. Then ongoing patient evaluation, where to send the patient to ICU, telemetry unit, especially when they have cardiac dysrhythmias, and place them in the ward bed. Or you continue to do emergency department evaluation and discharge home. If the patient had intentionally took the medicine to harm themselves, then psychiatric and social evaluation needs to be done before they send them home. And of course, continue to communicate with the poison control center. The seizure resulting from xenobiotics can be grouped into three. One, those respond to standard anti-epileptic treatment. As we mentioned earlier, benzodiazepines, second go-to is phenobarb, and third one is propofol. When you do a propofol, of course, the patient needs to be intubated at that point. Even benzos and phenobarb can lead into respiratory depression. So keep that in mind when you are using those combination of the medications. And the other group is requires specific antidotes to control seizures. They do not respond consistently to our standard anticonvulsant. For example, in isoniazid seizures, they require pyridoxine. Pyridoxine stops. None of the others will stop the seizures. The third group is the respond to initially to the treatment with the benzos, but leave the patient exposed to underlying and unidentified xenobiotics and continued electrical seizure that is happening. That happens with carbon monoxide poisoning and hypoglycemia. So you have to keep in mind, even if the seizure is stopped, just make sure there is no continuous electrical activity going on. That needs to be identified and treated appropriately. So when the patient comes with the first 5 minutes of managing patient with altered mental status, what are the things you need to do? Number one, give oxygen right away. Number two, check the sugar and treat with dextrose 0.5 to 1 gram per kilo. D50 for another adult, D25 for pediatrics, and D10 for neonates. Thiamine 100 milligram IV for an adult, usually unnecessary in children. That is to prevent Wernicke's encephalopathy. Naloxone 0.04 milligram IV with upward titration in adult and child. In child, you need to use appropriate dosages. So these are the four things need to be addressed right away, especially when the patient presents with altered mental status. GA decontamination. The administration of activated charcoal no longer considered as a standard or routine toxicology care for most patients. Should be based on specifics of ingestion, estimated quantity, formulation, in size of the pill or tablet, and time since exposure, concurrent ingestions, coexisting medical conditions, and the age and size of the patients. When there is undetermined, if you have NG tube in place, then one can use activated charcoal via if the tube is big enough to push the activated charcoal down. So that can be done. Eliminating absorbed xenobiotics from the body, how to eliminate it from body? Either by manipulating urinary pH, that is called ion trapping, or forced diuresis, hemodialysis to remove xenobiotics, and hemoperfusion, continuous renal replacement therapy, or exchange transfusion. How to manipulate The urinary pH. Number one, alkalinization of urine. It enhances the renal excretion of acidic xenobiotics. Has limited applicability. We do use alkalinization of urine in patients with salicylate toxicity and methotrexate toxicity routinely. The flip side is acidifying the urine to hasten the elimination of alkaline substances. Even though theoretically it does do elimination of alkaline substances, it's difficult to accomplish, limited value, and possibly dangerous. So the acidification of urine is no longer done routinely in clinical practice. The third is forced diuresis. We used to do 1.5 maintenance followed by LASIK chase. Right now, there is no indication for forced diuresis because of increased incidence of pulmonary and cerebral edema in those patients. So only thing with the urinary pH manipulation is alkalinization of urine that commonly we do in salicylate and methotrexate toxicity. So how to eliminate the drug? Hemodialysis is considered in patients with salicylate toxicity, methanol, ethylene glycol, lithium, valproic acid, or other xenobiotics that are either dialysable or cause fluid and electrolyte abnormalities. The hemodialysis is used more commonly in those circumstances. Hemodialysis also can help in patients with overdose with theophylline toxicity, phenobarbital, and garbamazepine. It's pretty much replaced hemoperfusions. Nobody does hemoperfusion. I have never seen one. So hemodialysis pretty much took the place of hemoperfusion. If the patient has taken non-dialysable xenobiotics or large molecular weights, plasmapheresis, and exchange transfusion. So when to admit this patient in ICU? There are patient characteristics and the xenobiotic characteristic. Does the patient have any signs of serious end organ toxicity, like renal failure, cardiac, or brain? Or the end organ effects are progressing? Or lab data suggestive of serious toxicity? So patient high risk for complications requiring ICU intervention, like seizures, unresponsive to verbal stimuli, level of consciousness impaired to the point of potential airway compromise, PCO to more than 45, systolic blood pressure less than 80, cardiac dysrhythmias, abnormal EKG complexes and intervals, especially QRS duration more than zero point 0.1 and QT prolongation. That usually happens in TCA toxicity, tricyclic antidepressant. A refractory or recurrent hypoglycemia. You already given D50 or D25 or D10, but hypoglycemia reoccurring. It is better to transfer the patient to ICU and monitor closely. Is the patient at high risk for complications such as aspiration pneumonitis, anoxic brain injury, rhabdo or compartment syndrome? Does the patient has other pre-existing medical conditions that predispose them to complications like alcohol, drug dependence, liver disease, acute kidney injury, chronic kidney disease, heart disease, pregnancy? Is the xenobiotics or the antidote is teratogenic? Is the patient is suicidal? In those circumstances, you should admit the patient to ICU. Sometimes xenobiotics itself warrants ICU admissions, like those with cyclic antidepressants, calcium channel blockers. Do you expect the patient to deteriorate rapidly from toxic effects? Is the onset of toxicity likely to be delayed? For example, the patient has taken sustained release preparation, slowed GA motility, delayed toxic effects. Does the xenobiotics have effects that will require cardiac monitoring? Is the amount ingested potentially serious or potentially lethal dose, or xenobiotic concentration is rising? Is the required or planned therapies unconventional, like large doses of atropine for treating organophosphorus or high dose of insulin for CCB overdose? Does the therapy have potentially serious adverse effects? Is there insufficient literature to describe potential human toxic effect? Is there any serious co-ingestants? So in those circumstances, again, the patient needs to be admitted in ICU for close monitoring and also the intervention that can be done faster in ICU than in other places. This concludes the seminar on toxic syndromes initial evaluation.